good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. And this is my favorite program of all, our monthly edition of Show Me the Science. High blood pressure, also known as hypertension, is one of the most common health conditions in all of America and all the world. But today we're going to learn about a rare, complex, and misunderstood condition called pulmonary hypertension. That's high blood pressure not in the rest of your body, but high blood pressure in your lungs. Pulmonary hypertension, or PH, complicates an all-important exchange of oxygen and carbon dioxide happening in your lungs and the ability of your heart to even get the blood flow through your lungs. It turns simple activities into major exertions. Today we're going to meet someone who's living with PH who is able to stay active thanks to lots of medications and oxygen. She'll help us understand the physical and emotional stress that in her case has no known cause or cure. We're also going to learn why PH is such a challenge to diagnose and ask about soon-to-be published science on a treatment that's aimed at managing symptoms and that may be a major breakthrough. And later, of course, we're going to check in with our own Doc Hawk, but first, let's go to morning rounds. We're talking live with Dr. Scott Mullen, an orthopedic surgeon here at the University of Kansas Health System, who's also one of the team physicians for the Kansas City Chiefs. He's seeing patients today at our Indian Creek campus before he flies out to work with the team in Las Vegas. So, Dr. Mullen, the other team doctors, I understand, are in Las Vegas already. Is that right?
Yeah, one of my partners, who's the head team orthopedic surgeon, Paul Schreppel, he flew out with the team on Sunday, and so he's there keeping an eye, and I'm looking after everybody as they go through practices and things as the week goes on.
Okay, well, Dr. Mullen, I understand you can't see me, but I just wanted you to know that I'm ready to go. I've been practicing a little bit. I got my football in my hand. It's an official Wilson football. It shows that I played with the Chiefs. It says Fantasy Camp on it. It's got a bunch of signatures. I know how to. I can put my fingers on the laces. I got my official hair. I got my number 15. So, dude, I know you have to leave here soon, but I just want you to know if there's any shortage out there, you talk to Andy for me.
Okay, we'll keep you in mind. I'm sure he's got you on a short list.
Well, he and Brent Veach, speed dial baby. So what's your role leading up to and during the Super Bowl?
Yeah, so leading up to the Super Bowl, we'll have training room a couple of times, trying to make sure that players who are, nursing any injuries here, hopefully after the bye week, most of everybody's going to be doing really well. But keep an eye on things and making sure that if anybody, has anything that pops up through the week or that's bothering them, that we're on top of that. And then on Sunday, we'll go to the stadium with the team like we always do and try to take the best care we can from the sideline and the training room and keep them in the game as much as possible and hopefully have a safe, healthy game. And it's going to be a great one.
Yeah, it's going to be a good one. So what's your prediction? Now, you got to have a prediction here.
Oh, we're going to win. Yeah, I don't know if there's really no other way to say it. I think this team has really turned it on here in the last part of the year. They've played great. They've just looked unstoppable in the playoffs, and everyone is really playing at a very high level, and so I'm very confident that we're going to bring back yet another Super Bowl trophy to Kansas City.
Awesome. And after 4 Super Bowls in 5 years, could have been 5, but that's okay. Does it still feel special?
Gosh, it is an incredibly surreal thing. If you asked me 10 years ago, you think you'll ever go to a Super Bowl as a fan, I would have said probably not. This will be my 4th Super Bowl that I've watched and participated in from the 30-yard line, standing on the 30-yard line. So it's an amazing accomplishment that this team has been able to pull off yet again. And everyone is special, and it's an amazing experience.
Yeah, it has been a special time in Kansas City. I grew up here, and I used to go to Arrowhead Stadium when it was like middle of December, and nobody else wanted tickets, so the neighbor would give them to me. It was 17 degrees. There'd be 17,000 fans in the stands, and Back then they played 14 games, and I think we were shooting for like 3-11 or something. And yeah, these are a little different days now, right? Some folks in the Chiefs organization have praised this
it's incredible.
Yeah, it is. Have praised this partnership with the health system, and even say it gives the team an actual competitive advantage. What do you think about that?
Yeah, I mean, I agree. I think, we have an amazing training staff with the Chiefs. Rick Bulkholder, the head athletic trainer, does an amazing job of managing his staff. Last year, you heard specifically a lot about Julie, the physical therapist, who helped Pat through his injury. And then, we're out there multiple times a week in organized injury clinic sort of situations. Dr. Shuppel and I are there most of the days covering, taking care of our patients through our normal orthopedic sports medicine clinics and the training facility. So we're always available to them. And I do think that having an amazing team of medical providers, both our primary care docs, orthopedic sports medicine docs, and all the athletic training staff, it really does create a significant competitive advantage, because if we can identify your problem, treat your problem, hopefully we can get you back out there playing safely, and that gives you the competitive advantage.
Yeah, that is awesome. And of course, Dr. Mullen, the question on everybody's mind is, do you get to take care of Taylor Swift? Are you a Swiftie?
I can't say that I'm a Swiftie, but certainly Taylor Swift has been a hot topic of conversation around the team and around the facility here for the last several months. I think it's an amazing thing for the two of them, and I saw Travis said that he's going to try to hold up his part of the bargain and bring some hardware home this weekend too. So hopefully his prediction is right, and go Chiefs.
All right, I love it. I know you got a busy clinical day and you got to head out today. Good luck. Bring back another Lombardi trophy. Make sure they know I'm at the ready. And you notice I didn't bring a guitar. I only brought a football, just saying. All right.
You got it. We'll let them know.
Thank you, sir. All right, here with me today at the desk are two pulmonologists who are good friends of mine, Dr. Tim Williamson and Dr. Louis Satterwhite. Dr. Williamson is also the Vice President of Quality and Safety for our health system. Dr. Satterwhite is one of our medical directors of the ICUs. If you need a little extra hair here, brother, I can help you out with that right there. Anytime you need it, I'm ready to go. Okay. Both of them have a special interest in today's topic, pulmonary hypertension. A special interest because they really help run our PH program here at KU, which is one of the largest, and if I may say so myself, one of the best programs in the country. If someone has regular hypertension, they're told to eat healthy, get exercise, reduce salt intake. But pulmonary hypertension is a much different disease, and actually a much more difficult disease to manage, and can be rapidly fatal if it's not treated. Dr. Williamson, tell us what's going inside, or what's going on inside the lungs and the blood vessels inside the lung of these patients.
Yeah, so in pulmonary artery hypertension, Dr. Satterwhite's going to talk about some of the different types of pulmonary hypertension. Pulmonary hypertension just means high pressures in the blood vessels will go from the right side of the heart to the lungs. And in the type that we're going to talk about today, what happens is, each of those blood vessels splits into smaller and smaller vessels. And so you start seeing proliferation of the cells, scarring in those very tiny blood vessels. And as that starts to accumulate, it's really like blocking the plumbing. The pressure then starts getting higher. And of the two pumps, the part of the heart that pumps blood to the lungs, it's pretty wimpy. It's not used to having to do a lot of work like the left side of the heart is. And so maybe that next graphic, as that pressure builds and that part of the heart's that right side of the heart's trying to pump against those pressures, it gets bigger trying to accommodate, and then it gets sicker. And as it gets more sick, then we start seeing throughout the process, we can see shortness of breath, but then you start seeing people gain fluid buildup. Sometimes as it advances, they can have chest pain or passing out. I think you'll hear a little bit about that in a second. And it's unfortunately not recognized very, very frequently because it's way down on people's list of what might be going on.
And to say, I think if I remember my physiology correctly, the right side of the heart has about 1/3 the mass of the left side of the heart. The left side of the heart's got to go all the body.
Yep.
The right side of the heart, I just got to get it across the lungs over to the left side of the heart. So when it gets faced with a lot of work, it just gives out.
Yeah, absolutely. Not only the distance, but just the pressure. So the pressure normally for someone our average ages, whatever that might be, that top number is probably 25 or 30. And sometimes we see, I think my personal high that I've seen is 140. in the lungs, but that part of the heart isn't designed to do that.
It's not supposed to work like that. It's
No.
like that's a pressure that your body would have, not
Right.
your lungs would
Exactly.
have. Yeah, it kind of gives out rapidly, sort of like one of Hawkinson's workouts or something there. Yeah, okay. So, Dr. Satterwhite, tell us about the different types of the groups of pH and how did the treatments change for each group? 'Cause there are different kinds here.
Yeah, absolutely. So pulmonary hypertension, like Dr. Stites referred to, means that you have high blood pressure in the blood vessels going from the heart to the lungs. But with a lot of things in medicine, we fight against making some terminology complicated. So pulmonary hypertension refers to a whole group of problems that can be from a large number of different causes. The blood vessel changes that Dr. Williamson was referring to is specifically pulmonary arterial hypertension, so PAH, which can get confused with pH, which still refers to those high pressures, but can come from a whole list of things. Looking at the graphic that we showed earlier, it can come from back pressure from the left side of the heart, the larger side of the heart. It can come because of blood clots that travel to the lungs. It can come because of problems and changes to the lung structure itself. And each of those can result in those high pressures, but they come from different causes, and so they need different treatments. And so not only recognizing pulmonary hypertension is important, but it's also really important to try to understand and identify the different contributions so that we know what are the appropriate treatments. Because frankly, one treatment for PAH can cause problems or damage or worsening if it's applied in the wrong patient in the wrong setting.
Yeah, this is really important information because we know patients with pulmonary hypertension are at such risk for things like sudden death. Because that right side of the heart, when it starts to give out, man, it could just go rapidly.
Yeah.
Why do some patients struggle to even get diagnosed?
Sadly, and this has not changed over 20 or 30 years, the average time to diagnosis from onset of symptoms to diagnosis is 2+ years. And that's not changed despite education and outreach in probably 20+ years. And part of it is the symptoms that folks have overlap with a lot of other more common. So, you know, you think horses versus zebras, people are thinking about horses, but these zebras sneak in there, and so shortness of breath. A lot of times people are misdiagnosed as asthma or COPD. Chest pain, they're misdiagnosed as coronary disease, or not uncommonly anxiety, anxiety, depression, completely non-medical or not related sort of thing. So they have pretty wide range of symptoms that overlap with a lot of things that are more common. And so we've really tried to make a push for folks, if you have an unexplained shortness of breath, that some part of your workup has to be an echo or ultrasound of the heart, which is kind of the screening test for this disease.
And in fact, because they may have another disease like emphysema or COPD, we can blame that disease and not even go looking for the real problem. Is that right?
Absolutely, because we talk about the groups of pulmonary hypertension, and we wish life were that simple, that it was always just the one thing, but somebody that might have PH could also have had a blood clot, or they could also have had other issues.
Yep.
And so trying to understand to make sure you've identified the main cause, but also all the contributing causes, and there can be a lot of overlap, and it can be confusing at times.
Yeah, this is a tough disease to manage. But fortunately, over the last 2 decades, several new drugs have helped patients manage their symptoms. They're not really cures per se, but at least you have something more in your armamentarium that you can give to your patients. So talk to us about some of those meds.
When I was in med school and we actually had books, there was one paragraph that said, primary pulmonary hypertension affects women of childbearing age and is universally fatal, and there are no treatments. We now have 10-ish, FDA-approved drugs. And what is amazing is for the vast majority of my patients, and Lewis can comment, it becomes a manageable disease. It's still very serious. We still have to take it very seriously. In some patients, it still progresses. But it does a good job, and you're going to hear an example of this, of how it can be managed for long periods of time. I've had people I've followed for almost 20 years. And so, I hate to do this, but I have to give a shout out. Our first therapy for PH was a continuous infusion, came in the late 90s. We had nothing before that. Some crazy guy thought we could do that here at KU. He was stressed almost exclusively by LL Bean.
That's a long time ago.
I'm just saying, he's improved on that front.
Yeah.
But Dr. Stites was the one who brought that here and really started our pathway down pulmonary hypertension, is the grandfather or godfather of PH.
Grandfather, thanks. Well, you know, the truth is that we should all be glad that that first patient was a complete responder to IV prostacyclin and had a miraculous response, because that made us want to do a second patient who also got better, and then a third patient who didn't. But we thought, okay, 2 out of 3 is not bad.
So now we have we have pills, we have inhaled medicines, we have continuous medicines that really help improve quality of life and probably length of life. The studies for that are hard to do. And now have grown a program, the Pulmonary Hypertension Comprehensive Care Center, that's hard to say, PHCCC, that really uses all those different medicines, because you have to figure out how to use the right medicine in the right patient to get the right results. And so just one of our colleagues isn't here today, Dr. Leslie Spike, so there's 3 docs, 3 fabulous nurses, a bunch of research coordinators, and it's just like we talk about the chiefs being about the team. This is really about the team, and it's all working together to use those medicines to find the right medicine for the right patient.
Yeah, we know the team actually does most of the work while we sit there and yap, and they do a tremendous amount, especially that nursing staff. So, all right, well, let's talk with someone who's actually living with pulmonary arterial hypertension. Ashley, I'm going to try this and get it right. McGilvray.
That's it, yes.
All right, maybe if I could get 2 in a row. I think I'm just going to call you Ashley. She's going to join us remotely today. Good morning, Ashley. Take us back to when you were first diagnosed in 2020. You were living in Florida at that time, and I understand that one day you just collapsed.
That's correct. And I had some breathing trouble leading up to that, and I was actually referred to a pulmonologist to get an asthma test. But one day, the day you're referring to, I was carrying, excuse my voice, I was carrying a crate down my apartment stairwell of books, and I tried to go back up to get to my coffee, very important, and on the way back up, I collapsed, and I was immobile for about 5 minutes, felt like my head was in a fishbowl, and a neighbor thankfully came out, found that my lips were blue. I couldn't get up and walk, my legs were like noodles, so I was taken to the ER. And that is what started this long journey. They found significantly abnormal results when they did tests there.
Yeah, it sounds like they must have. If they found those results, what was the key test? Was it an echocardiogram, or what did they do?
They did an EKG and somebody can correct me, it's something like a dimer or something or other.
Oh, a D-dimer,
yeah, a D-dimer, thank you, yes. And both of those were significantly abnormal. So they referred me on to a cardiologist who then did the echocardiogram, and I failed a stress test. And that's what I then had a family doctor in South Carolina who specialized in PH. She contacted a doctor in Tampa where I was living and said, I believe that Ashley has PH based on these results. And so that was Dr. Alvarez who ended up seeing me in Tampa. And he did a right heart catheterization to fully confirm that I did have significant pulmonary arterial hypertension.
And I think it's worth calling out real quick that passing out, or we call it syncope, is one of the biggest red flags for pulmonary hypertension. That means that right side of the heart's not getting blood through the lungs and then to the left and up to the brain. And so that's one of the most scary red flags we have in PH.
Yeah, and it's usually one that doesn't go well if you don't get into therapy really fast, because that's a sign of more advanced disease.
Yep.
Now, you ended up moving to Kansas City to be close to your family and support system, and you're actually seeing Dr. Williamson now. And how's that gone? Because he's kind of goofy. I'm just going to say, you should ask him. He's kind of goofy.
Yes, he's quite a troublemaker, isn't he? But no,
Yes.
I've been very thankful for his whole team. And when I came here, I was still, I had been trying several different medications. Dr. Alvarez literally saved my life. After he confirmed that I had PAH, I passed out again and then passed out in the ICU. And it was him continuing to push the therapy that the hospital wanted to take me off of. They thought that was the reason for me being so ill. He kept pushing. But when I moved out here, I had somewhat stabilized, but was trying out different medications because the IV is just not good quality of life. You're living in a constant state of fear with that. So we were trying different medications, and Dr. Williamson has been great to help me finally be on a medication that's really manageable.
Yeah, you know, it is. And back in the beginning of this disease, when the only therapy we had was IV, and you had to wear that big pump all around. You could never let the pump get interrupted. One of my patients was in a car accident in a snowy Christmas Eve night. And I thought, okay, I'm going to be driving down I-35 to Ottawa to try and get a new pump for her and try and bring one from one of the supply from the pharmacy or whatever. And oh my God, fortunately, she got an EMS that got her to get you faster than that. But and is still alive to this day. So Ashley, talk to us a little bit about what this means for your daily life.
Sure. Well, back when this first started and I was so sick, I couldn't even sit up by myself. My family would have to lift me up. They'd have to roll me to the toilet, sit me down, literally pull up my pants for me. But now today, to where I've stabilized due to the medications being so successful, I still wear oxygen regularly. I have to wear it anytime I'm going on a walk that's going to last more than 5 minutes. I'll be wearing my oxygen. If I know I'm going to be doing something that will cause me to be emotional, I'll be wearing my oxygen. For some reason, bending over is very difficult for me, things like jumping. And there are activities that I can no longer do that I used to love. I used to be a long distance runner. I can't run anymore. I was a singer and went through about a 2-year period where I couldn't sing at all. And thankfully, I've gotten so much better that I am able to sing every now and then now. But it has caused a change in career path too. I was a teacher beforehand, and I had to resign from teaching, unfortunately, due to the high levels of stress and just the exhaustion that comes with it. Fatigue is one of the biggest symptoms of PAH. So you really have to find something that will allow you to have minimal fatigue. So I am actually working though full time now, and I thought that would never be an option. So I'm just grateful to be where I am today.
You know, I'll tell you what, Ashley, people like you make our jobs a whole lot easier when you find people who are self-determined and are going to work hard to try and master that disease as best they can. That's it. You just told us a great story, so thank you for that. Dr. Williamson, Dr. Satterwhite, there's a new drug on the horizon. Sotatercept, I think. I said it pretty closely.
Sotatercept, you got that in the last name.
Yeah, not bad. That's 2 for 2 today. Ask me if I can get Satterwhite right. Probably not. So talk to us about sotatercept.
So it's a medicine that is still in the pipeline of being evaluated and hopefully approved to be on the market in the future. That has been studied relatively extensively at this point, with many of the results published from a couple of different trials. But it is, Dr. Williamson noted that we've got medicines that you take by pill, medicines that you breathe in, medicines that go in continuously through an IV. This would be both a novel way to deliver the medicine and a novel mechanism of the medicine. It would be given, is given as a shot once every 3 weeks, and works in a different way from the 3 different families of medicines that we have now. And the hope is that this is really the first medicine that works at reversing the problems that Dr. Williamson talked about at the beginning of the show in terms of what's going on inside of the blood vessels. Exciting in that it showed improvement in patients already on the therapies that we have. So Ashley taught us so much about her journey, but hopefully we can take people that have done well with medicines and do a measure better and do better and continue to expand what people are able to do in terms of the quantity and quality of their lives.
Is this and I know you brought it, I see you have the journal article with you, you've got it all marked up.
I'm the nerd. I mean, this is major. You know, we've had new drugs come down the pipeline, but this is the first new class of drugs, probably at least 10 plus years, maybe more. It's been a long time since we've had a new class, and it's one of the first ones to really make a difference in that remodeling, reversing those changes. So we saw that on improvements in right heart cath. But to Dr. Satterwhite's point, the patients in this trial, because the days of doing placebo-controlled trials where someone is on nothing versus drug, you can't do that ethically anymore because we have medicines that work. And so the fact that 40% of them were on a continuous IV pump or 60% were on 3 drugs, having improvement both in their pressures as well as their walk is amazing. The challenge is going to be, it comes up for FDA review next month. I think it'll be approved, but then it has to get to market. All these drugs are incredibly expensive. They range anywhere from $10,000 a year to $300,000 a year. This probably will be around $400,000 a year. And so getting the payers to pay for these things, for new drugs. And then I think there's going to be a run on this new drug because the PH community is incredibly excited about it.
How could you not be?
And
This is
so
great news.
trying to figure out who can get it when is going to be a good challenge to have, but will be a challenge coming up.
So
Which goes back to the team that we have. So, be one thing that's easy enough for someone to say, oh, I think this person's appropriate, but we have this team of nurses and pharmacists and everyone else that will work with us to find the right patients and help them through that process to get the medicines.
They do all the work. They're the boss. I just sign where.
We know that.
I just sign where they tell me. So.
They also tell me that too. So the clinical trial showed that after 24 weeks on the drug, the 6-minute walk test improved by more than 30 meters. Tell us what that means. Translate that.
It's a really super complicated test. You walk for 6 minutes.
Between orange cones.
Between orange cones.
All right, I can do that,
But
baby.
it's a way of functionally assessing somebody in a standardized way. That was the first endpoint for clinical trials for PH, and that's remained an endpoint. And we've had drugs approved with as small of an increase as 14 meters, so 45 feet. This is 90 feet, but again, on background therapy. So it's one of the ways we look at, does the drug work? It's pretty simple. And then we use it as a way to follow patients who are on therapies, knowing that other things get in there, like knee pain or bad shoes or other things that will change your 6-minute walk. But
So do you think that the sotatercept, however they say that, sotatercept, that drug could end up being the first-line therapy, and if it can reverse some of it, actually, the earlier you give it, the better you do?
We're going to learn that over time. It's a great question, and one of the things that we have when we have drugs come to market and new opportunities, this was appropriately studied in addition to therapies that we know that work. Where it's going to fit into the guidelines, I think we'll learn probably a lot more this summer. We have a large international meeting once every 5 years, and I think it's timed well to occur this summer. And I think we'll have a lot of people discussing and talking about where does it fit in line. And there's other things to consider, because while it's an injection every 3 weeks, that's still more in terms of quality of life than taking a pill once a day. So where it fits for which patients and which situations, we're going to learn over time.
All right, well, we're hoping that's going to work out great, because what a blessing for patients to be on a therapy that could potentially reverse the disease. And then you can just say, that'll even shift more pressure to make the diagnosis right earlier, because that could be a big deal.
it's going to be key to make the diagnosis early, because once the RV starts filling, then you got to have therapies directed at supporting the right ventricle.
When that right side gets unhappy, that's tough. All right, we're going to be here to answer your questions. We know you're going to have some. Please send them in using the info on your screen. That includes the chat on YouTube, Facebook, or the X platform, and emailing the Medical News Network. Let's check in with Doc Hawk. Doctor? Oh, yeah. Wait. Oh, here we go. Here it comes. All right. Notice how my arm angle was correct. How's that COVID count doing?
Yeah, the COVID count, it's kind of plateaued the last 2 weeks. We were up to the low 30s, and then down. Last week, 23. This week, 24 active COVID inpatients. So hopefully we can start to see more of a decline there. And we know that nationally, actually, as the last week of January, they had under 1,000 deaths for that week attributed to COVID. That is good news, because the last time we had that, Steve, was in May of 2023. So hopefully overall community circulation of the virus is decreasing, and of course then hospitalizations and severe disease as well.
Yeah, it's equivalent of a darn big deal there. But the COVID numbers at least have been a little flatter. We got some graphs to look at, I think, right? Let's take a look.
Yeah, and these are COVID. Again, these are a week behind because we get our data and calculate it. But what we are seeing here, obviously, if you go to that far right side, we can see that the green is COVID, the orange is RSV, and the blue is influenza. And what you can see is we had a big spike there, a few weeks back. It did improve overall for all of the viruses, but the last week that we have data for had a slight increase in overall admissions for influenza, COVID, and RSV as well.
And just to say, even if you put influenza and RSV together, it's nowhere near the number of COVID patients we have. For those people who say COVID's gone away altogether, just not true. We still see a lot of COVID. We still have 4 patients on the ICU, 2 of them on ventilators. For those folks, it's still bad. Certainly nothing like what we had in the last couple of years.
Yeah.
But it's not gone, and especially for people with underlying chronic diseases, it can still be really difficult to manage. I think you had a couple of other graphs you wanted to show.
Yeah. Yeah, so this is our COVID inpatients, and again, this is kind of mirroring what we saw in the last graph with the orange bars. And what you can see overall is we did have that high spike a few weeks ago, a sustained spike of COVID admissions week by week. What you can see now is at the far right, we did dip a little bit, but the last week we were up a little bit as well. So hopefully we've started to plateau, and now as we move forward, we can start to see more of those dips as well. And this is from the CDC. This is looking at ILI, or influenza-like illnesses. This is visits to emergency rooms, urgent care, and primary care places. What this shows is that there are trends from several years. The most recent trend there you can see is kind of the line that is just abruptly stopped. That is for this current season. You can see that there was a peak similar to last year's peak. It did come down. It now looks like it's maybe starting to plateau. So we are not decreasing, but there may be some sort of second wave that may be coming. We're hoping not. We know that second waves can come, as you can see in that graph there. There is that line with several peaks, but we'll just need to wait and see. Again, influenza, RSV, COVID, other cough and cold viruses, those all account for the ILI's influenza-like illness. And I would say that from the data, the early data from this year's influenza season, there were 230,000 hospitalizations with 14,000 deaths from that. The vast majority of influenza circulating right now is the influenza A, and most of those are the H1N1, and second would be the H3N2. What we do see, and what we have seen in the past, is that initially there is that influenza A, and then later on, if there's a second spike or a recurrence, it tends to be an influenza B surge as well. So we'll just wait to see. It is still fairly early. We know that we really track a lot of this through the end of March into early April.
All right, we got our fingers crossed for a good response this year, and hopefully we're going to keep that.
Yeah.
And hopefully we won't see that second wave. But I, like you, am just a little nervous about some of the stuff we're seeing going on with COVID in the community right now. A little bit of an uptick. Alex Del Cid is watching for questions from our community. Alexis.
Hey, Dr.
Alex, sorry. Alexis, I know you are.
All right, we're on a nickname basis. You can call me whatever you want.
I'm going to call you Stripey. You got that kind of stripey
All right.
thing going.
Okay, I'll take it. We're having some really good questions come in, so I want to get to Yen Liang. He wants to know, is pulmonary hypertension hereditary, and how can it be prevented?
Oh, great questions right off the top.
There is a familial form or inheritable form, and we actually have quite a few families in Kansas that have the heritable form, kind of centered, interestingly, in that north central part of the state. It is, we think, a fairly rare form of pulmonary artery hypertension compared to other causes. So we don't routinely test for those genetic issues, but it is it's possible, but at least we think fairly rare.
You said, I just have a follow-up. You said it's in the north central part of the state. Does that have anything to do?
There seems to be
is
a
there
cluster,
like a
right?
pocket of people there?
There seems to be a cluster, and we don't, we've never been able to fully study that, but it's unclear. It's if there are there's probably pockets of families that don't know that they are related to the degree that they are. But it's hard to know if there's environmental impacts or other things that could be driving it.
Yeah, exactly. Yeah. Okay.
Jean has a question, and Jean, you're being unfair to yourself. Jean writes, stupid question, but it's not a stupid question. I can tell you right away. This is a complicated show, so other people probably have this question. Jean wants to know, when the doctors are talking about the right side of the heart or the left side of the heart, Jean asks, are you talking about the right side to the patient, or are you talking about the right side to you, the doctor looking at them?
Even I can answer that one.
Go for it.
Well, the right side of the heart means your right side. The left side is your left side, not ours. So, yeah, the right side of the heart's the one closest to your right arm. The left side of the heart's closer to your left arm.
So when he's looking at the screen, when Jean or the viewers are looking at the screen, if you're saying right, it's probably he's looking on his Jean's left?
And it's somewhat just medical nomenclature. Really, the heart is way more complex than to be on one side or the other, and it's really as much front and back as it is right and left. What it's referring to is where it is working as a pump in terms of circulation of blood through the body, and what it's playing a role in terms of delivering oxygen or pumping the blood to go pick up more oxygen from the lungs. So when we talk about the right side of the heart, we're specifically talking about the pump that pumps blood to the lungs.
Yeah, and the problem is our graphics confusing people. Hey, can you pop that graphic back up? It had the heart on it. It's kind of split for just a minute.
That will help.
I know. It took me a minute to figure out what the actual question was.
Yeah.
Yeah,
a lot of times in clinic, I will do a.
So here's the challenge.
Yeah.
So on your screen, the blue one is on the left, but really that's the right side of your heart. I think that was the confusion.
Yes, that's what Gene was
and
asking.
the red one is the left side, the left ventricle. And you can see the left one's a whole lot bigger because it's got a lot more, it's like the muscle wall is 3 times the size of the one on the blue one, which is on the right. And the reason the one on the left is red is because it's got oxygen. The one on the right, the blue one, doesn't have oxygen.
And sometimes in clinic, I will draw a stick figure of the circulation, and it's interesting. And this graphic that you had up is the same. You know, we have 1 heart and 2 lungs, but as we talk about the circulation, we really I will draw 1 lung because it goes the same place, and 2 hearts because the heart is 1 organ. It sits in the center of your chest, but it functions as 2 totally separate pumps.
Yen has a question. Yen wants to know, is it more common for people with pulmonary hypertension to have peripheral arterial occlusion? Then you've got to explain what peripheral arterial occlusion is for the rest of the viewers.
I would say not necessarily, and it really depends on the age group that you're talking about. So peripheral arterial occlusion is that vascular disease or blockage in the that often comes with high cholesterol or smoking or age, that you don't get blood to, say, your feet or legs very well. We do have populations that are older, that there's overlap, but just by nature of having pulmonary hypertension, it's not an increased incidence of that. So you don't have to worry about that, Ashley.
And Ashley, you may be a little too young for it. Williamson, on the other hand, I thought you don't have to worry about that.
Yeah.
Adrian Cecilia wants to know, is the EKG always abnormal in pulmonary hypertension?
Another great question. It's not always abnormal. It is a really important screening test for people that have symptoms of shortness of breath or chest discomfort, and it is oftentimes abnormal, and one of the things that can lead us to the answer. And Ashley did a great job earlier talking about her journey through some of the diagnostic testing, but ultimately that is one of the tests that can lead us to the ultimate test that we're always trying to emphasize for our patients, that really lets us know definitively whether or not pulmonary hypertension is present and helps us figure out the type or the group that we talked about earlier, which is a right heart catheterization. So the EKG is an important part. It can be normal or not have significant abnormalities early on or in mild disease, and so it's important, but it's not the crux piece, really.
We have a couple of questions for Ashley, and I'll combine them. Marie wants to know, are there any bad or uncomfortable side effects to the medications you have to take? And then Louise wants to know, what medications are those? So do you have side effects to the medications, and what do you take?
Sure. Well, I'll kind of walk through the 3 medications, main ones that are treated or that you're treated with. So I started with the IV, and that causes flushing of the face, so you become really red. My neck flushed a lot and still flushes today. And as you're brought onto the IV, you go through significant ramifications too until your body gets used to it. So you might have side effects that exist in the first few months that will go away over time. But lasting ones were diarrhea. Unfortunately, all 3. Diarrhea is a common one. I went then to what's called the subcutaneous method, which is it looks like something that a diabetic would have. It's a little pump that goes into your stomach. The reason it didn't work for me is I developed high allergies to the glue that is used to attach it to your body. However, the side effects with that one, that was the most pain I've ever been in my life. The medicine, when it hits inside your body, it feels like your body's lit on fire. So you are just in a week of pain. The PAH community refers to it as Hell Week. So you're on really heavy pain medicine during that time. I was bedridden, and unfortunately you have to start that over every time when you're reapplying the medicine. So about a normal person should have to reapply that about once a month. I was having to do it every week, so I never got to escape my hell week. And then finally, I'm on my new medication. Yeah. The new medication that Dr. Williamson got me on, and I'm so thankful. This is called Tyvaso, and it is a breathing medicine. So I take 15 breaths of this every 4 hours, except when I don't have to do it while I'm asleep. So the side effects with this, you'll get a temporary sore throat and temporary cough. But for me, it goes away within 15 minutes. But unfortunately, diarrhea is a side effect of it, and flushing still. My neck, you can even see it right now. I get really, really red. And then I'm on pills as well. One I'll talk about is a clinical trial drug called ambrisentan. And with that one, it causes severe deformities of a fetus. So unfortunately, I cannot get pregnant while on that medication. It would also be fatal for me to become pregnant, or could be. And then tadalafil is my other one, and that causes diarrhea as well.
Boy, you're a trooper.
That's quite a pharmacy, isn't it, these guys? This is
That's a lot.
still a tough disease. And Ashley, you just presented that in the most pleasant way anybody could possibly do.
We have one more question. Oh,
with it, so it's okay.
go on.
Oh no, go ahead.
You're so good at explaining things, and you're so open and honest. This is going to help so many people. Really appreciate it. We had one more question from Betty. Betty wanted some clarification. We talked about if it's hereditary. She wants to know, is there a cause, like a specific cause that you have been able to narrow down?
There are specific genes that have been identified, and then there's a very large nationwide study that's going on to identify additional genes. So there's something called a BMPR2 mutation. Like, I know what that is. I don't know. That sounds fancy, but there are genes that have been identified that we know we can identify, but there's probably others out there that we haven't identified yet that get passed on through families. Again, fairly rare. But there's work nationally to not only identify the genes, but tie together. It's called PVdomics, but it's to tie all the different pieces to try to figure out what are the commonalities. So you take the genetic test, you take the right heart cath, you take the echo, you take the history, the other diseases, and trying to combine that so we can have more precise treatments in the future.
And Ashley, as I understand, you're idiopathic, which is a way of saying, well, there is a cause, we just don't know what it is. It's the fancy way of medicine, physicians being able to say we don't know when we say idiopathic.
Yep.
That's correct.
All right. Alexis, one more question, or are we done?
We have plenty of questions coming in. Denise wants to know, no, I'll ask Alex's question. Alex wants to know, Ashley, who else have you met with this disease? Have you met anyone just randomly in the world?
I have yet to meet someone with this disease, actually. I have communicated with people online. Obviously, we have little Facebook groups, but I've not met anyone in person yet that has this disease.
Wow.
We used to have in-person support groups here, and with COVID and this vulnerable population, those stopped. We probably need to look at restarting those at some point, because people do feel very isolated because you don't know other people with the disease.
Yeah, you get a Zoom room going.
Yeah, and despite not being able to have the in-person support group meetings currently, we both and our partner Dr. Spikes all have patients that have made it clear that they'd be willing to serve as resource. So sometimes we'll have someone with a new diagnosis, and it is obviously a scary thing, and a lot of information coming at you quickly. So sometimes we can connect one patient to another so that they can give shared experiences and some of the tips of how they managed and coped and expertise.
I was just going to say real quickly, there is a national conference every other year that's really focused on patients. It's also for docs, but it's focused on patients, the Pulmonary Hypertension Association. It's in Indianapolis in August, I believe. So for people with PH, that's a opportunity as well.
Yeah, that's pretty cool when the patients come together with the caregivers and everybody sees how hard they're working, and I think that can be pretty inspirational. Well, Ashley, thank you for being on the program. Guys, this has been a great discussion. I want to hear some final thoughts, and Ashley, I want to start with you. Your final thoughts for the day.
Sure. Well, I'll address two groups then, so two thoughts, if that's okay. Please. First, I'll address my PH warriors out there that I just encourage you to not lose hope. I've found that God draws near to the brokenhearted and saves the crushed in spirit. And so I just hope that you continue to cling to him and that you come to know who he is, and don't be afraid of getting stronger. Even if all you can do is stand up, do that multiple times a day. Keep trying to get stronger. And then to the second group, those who don't have this disease, you can help us by donating to research. Obviously, what you heard Dr. Williamson say earlier, if I had this disease even 20 years ago, I might not be here today. So please help us. The people who have my disease, IPAH, we're 4 to 6 people in 1 million. So it's very, very small. And so obviously we need your help getting research done.
Man, you're awesome, and I certainly hope you've blessed with this, your presence at this program today. So thank you for being on it, and I hope you get on that new drug. I hope it works great for you. Dr. Satterwhite.
Thanks, Ashley. I certainly don't be following you with closing messages, but I think to just try to build on what you said. I think Ashley has done a great job of sharing her experience and what opportunities we have to help people currently. But even with the medicines that we have now, we have a lot of room to improve. So we have patients that probably wouldn't be with us today, but they still deal with limitations from their disease as well as side effects from their medicines. And we are really excited about what we have ahead of us. And it has really grown very quickly, and excited about what the future brings for treating this.
Dr. Williamson.
Yeah, Ashley, thank you. You did such a wonderful job. This is a great time in PH in that we've got new things coming down the pipeline. Perseverate. If you're not getting the answers about your disease or your shortness of breath or your symptoms, stay with it until you find someone who can get to the cause of it. Sometimes it's PH, sometimes it may be something else. And we've gone from a universally fatal disease to drugs that let people live their life. I've had patients who ski, who travel the world, who can't do all the things they did before, but do a lot of things. And I think that will only continue to get better. And as Ashley said, donating to research will help foster that. I don't know if in my lifetime there'll be a cure, but I certainly firmly believe in Ashley's lifetime there will be.
Well, I hope you live a long time, and I hope that you do. There it is. And just to say, for patients with more advanced disease and the drugs stop working, there is still lung transplantation, which can sometimes save a life and really be a remarkable thing. I know I've had a number of patients over the years with PH and ended up getting them transplanted, and can be. I still follow one. She's 22 years out of transplant, and she had the drugs that can cause PH, and she had taken fen-phen. Doc Hawk.
Yeah, again, echoing Ashley's message. I think it was a great message. Also, everybody have a safe weekend. Hopefully you're getting ready and making plans. Be safe. There still is time to get vaccinated if you need your updated vaccines, especially for influenza. All of those are still available. There's still some time within the respiratory season, so please go get vaccinated.
All right, to all of our audience, remember, we've talked a lot about faith, hope, and science. You heard from Ashley today the importance of faith in your God and your family and your friends and in each other. Hope, which really sustains us, and I think is one of the most important things in medicine. And then when science gets it all done and delivers something that's new and remarkable and a breakthrough, it is a miracle. And it is a pleasure to be able to be a physician in this modern age when these things come to pass so rapidly. Faith, hope, and science is a very powerful combination. Thanks everyone for watching and listening. We'll be back next week. In the meantime, show us your science. We'll talk to you soon.
From med student to patient, you've seen this doctor as an expert on our show before. This time he's the patient sharing his personal journey with the same heart condition he now treats.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now,